the panel discussion session. Please write your questions in the Q&A. We will answer it in the end of this section. So next speaker is Dr. Deegan. Dr. Deegan is an associate professor in the Department of Biochemistry and Molecular Biology. The focus of Dr. Deegan's lab is to reduce side effects associated with cancer therapy. Dr. Deegan, it's all yours now.
Thank you very much, Dr. Lin. So I'm excited to have heard the last two talks and really emphasizing the importance of trying to mitigate injury associated with the cancer therapy. Our work is really trying to reduce the side effects associated with both radiation and chemotherapy. And we know that as was well documented in the first two lectures that we've heard so far, that there is a high incidence of both acute and chronic side effects that are associated with both anal and rectal cancer patients. And both of these patient cohorts have a fairly long, good 5-year survival rate. So these patients are living a long time after their treatment. We want to improve the overall quality of life for these patients. So we know that for radiation, the toxicity that occurs is mainly through the production of free radicals. And so water is lysed, and when that water is lysed, you produce this very reactive free radical called hydroxyl radical. And this will interact and damage with any, part of the cell that it comes in contact with. And in the tumor, you're going to see more DNA damage because those tumor cells are dividing more rapidly as compared to a normal cell. And so we'll see preferential increased DNA damage in the tumor, and this will cause that tumor to shrink. However, if you don't completely eliminate the tumor after radiation, the surviving tumor cells have enhanced free radical production. And in this case, superoxide is this radical that is enhanced, and this acts as a signaling molecule to upregulate both HIF-1 alpha, also NF-kappa B, which goes to promote the survivorship of that tumor. So we see more vessel regrowth in the tumor, and we also see more tumor survival. And this, of course, accumulates to having increased tumor regrowth. Now, in the normal tissues, we don't see the same type of response for two reasons. One reason is of course, that radiation is is focused to the tumor, so that the normal tissue don't get quite as high a dose, but also those tumor cells, again, are not dividing as quickly. So we don't have as much direct cell death that's occurring in those tissues. What we see is actually a response to the radiation, which is an increase in the cell's ability to produce its own free radicals. And so we see an increase in this NADPH oxidase enzyme activity. In particular, one of these is NOX4 that's very sensitive to radiation. And these oxidases actually produce endogenous levels of free radicals, superoxide and hydrogen peroxide, which also act as signaling molecules to upregulate TGF-beta, which promotes fibrosis and then ultimately causes tissue injury. So we speculate if we're able to remove the superoxide and or hydrogen peroxide of the normal tissues, we'd be able to prevent that tissue injury. But in the tumor, we would hopefully be preventing this tumor regrowth, but we wouldn't be interfering with that initial tumor killing. So our laboratory has been working with these SOD mimics for several years. So these drugs are mimicked after the enzyme called superoxide dismutase. And so superoxide dismutase, or SOD, specifically scavenges superoxide. And so this manganese in the center is surrounded by positively charged nitrogens. And this allows that negatively charged superoxide to interact and be able to be reduced back to regular oxygen. So these compounds are now in phase 1, phase 2 clinical trials in several different cancers. And Dr. Chi Lin is going to actually present our data that she's been conducting in anal cancer patients with this drug here on the end. So Radiation is known to cause fibrosis through alterations in fibroblasts, and there's also other cell types that are involved. But the fibroblasts are really the cells that help to lay down that excess collagen, which causes the fibrosis. So we know there are particular morphological changes that occur after irradiation. So we have some early effects are that we can see some cell death, although that doesn't happen real often. We also can have cells become senescent, and we can have cells that start to turn into a myofibroblast. And this myofibroblast is an activated form of the fibroblast that actually is responsible for laying down that collagen. So in a couple of days, you'll start to see these activated cells shown here in red, and these are the ones that are responsible for laying down that collagen. This happens, months to years after irradiation. So this is not a quick response. So it takes a while to do this, but and we've shown that free radicals are involved with this progression and actually involved with turning on TGF-beta signaling, which can then lead to this aberrant collagen. So we performed some experiments where we isolated fibroblasts from rectal tissue from mice, and we grew them for about 2 weeks. And then some of these cells we exposed to radiation, others we exposed to radiation with or without the BMX drug. And we know that when a fibroblast becomes activated, it gets larger in size. And so we looked at cell size, and we showed that the BMX compound was able to inhibit that increased enhancement of the cell size after radiation. We also looked at the activation of these fibroblasts through its ability to contract collagen. And I'm going to show you some data on that after I get through this slide. And also, as I mentioned before, these senescent cells are also prevalent after radiation. And it's thought that these senescent cells actually secrete a pro-inflammatory environment that actually promotes the activation of these fibroblasts as well. And then finally, we looked at some of the signaling pathways involved, and we showed that our BMX compound is able to inhibit some of the pathways involved with the TGF-beta signaling pathway. So I'm not going to show you that data either, but so we have data showing that in vitro that these drugs are able to protect these fibroblasts from becoming activated. So this is an example of an experiment that we conducted where we looked at the ability of these fibroblasts to contract the collagen disc. So a normal fibroblast would not be able to do this, but an activated one can. And the activated one, again, are the ones that can actually cause an increase in collagen. And so we have TGF-beta here as a positive control. So we irradiated or we treated with TGF-beta, and you can see that the disc size has shrunk considerably, indicating that these fibroblasts are activated. When we treat with BMX, you can appreciate that these discs are remaining at the same size, indicating that those fibroblasts are not activated, and that's the data shown here, quantified below. We also looked at senescence. Again, radiation is known to induce a senescent phenotype, and that's shown here in the pink cells. So we see over a 2-fold increase in the senescent cells after radiation. And treatment with the SOD mimic is able to blunt this so that we don't see this enhancement of senescent cells. So now we wanted to move in and look to see what's going on in vivo. So this is work that I did actually in a collaboration with Dr. Chi Lin, where we actually irradiated mice on a Linac irradiator here at UNMC. Obviously, this is a huge mouse. This isn't to scale, but we've actually placed the mouse on a CT imager. We got the image, and then we were able to irradiate just to the rectal anal tissue. We gave 20 grays of irradiation using the Linac irradiator, and then we gave BMX 1 hour before we irradiated, and then we also gave it 5 days after radiation, and we harvested the animals at 9 days post-irradiation. And a couple things that we noticed just externally on these animals was that animals that were treated with irradiation alone at this 9-day time point all had diarrhea, and they all had hair loss around the anal region. In contrast, animals that were treated with the BMX compound did not have diarrhea and also did not have hair loss in that in the anal region. We also looked at the weight loss of these animals, and the animals that received radiation alone had the most weight loss. Animals receiving the BMX compound were able to be just protected from that excess weight loss. And when we look at the overall normal tissue damage, looking at both histologically as well as external damage, we were able to see that radiation caused, of course, a significant increase in the normal tissue injury, and treatment with the BMX compound was able to protect from that. I'm not going to show you the histology, but the histology also showed protection as well. We also looked at markers of oxidative damage. So this is in the rectal tissue. We looked at 3-nitrotyrosine, which is a marker of nitration of proteins. This is a known marker of both nitrogen and oxygen damage. And you can appreciate the green staining here is the 3-nitrotyrosine marker. This is our control animal, there's some baseline amount of 3-nitrotyrosine staining. Radiation significantly upregulates this, as is quantified over here on the right. Treatment with the BMX compound is able to blunt that. We also looked at lipid peroxidation as another marker. So this is 4-H&E, 4-hydroxyneonol. And again, in our control tissue, we see some baseline levels of lipid peroxidation. When we irradiated our animals, you can see that there is a significant upregulation of lipid peroxidation, and treatment with the SOD mimic was able to severely blunt this lipid peroxidation. So the drug is working as we postulated, that it is inhibiting these free radicals from forming and protecting those tissues from oxidative damage. So as has been illustrated in the last couple of talks, and I'm sure everybody here is well aware of the standard treatment for both anal and rectal cancer, and they're a little bit different. Again, so for rectal cancer, it's mainly 5-FU or FOLFOX, and treatment followed by radiation therapy, followed by a second round of chemo, and then usually surgery is followed after that. And then for anal cancer, it's a combination of 5-FU and mitomycin and radiation. So we tried to mimic both of these in some of our tumor models. But first, we wanted to look to see about toxicity, because we, again, know that these chemotherapy agents can cause blood toxicity issues. So we tried to mimic what goes on in anal cancer, where we're giving radiation in combination with 5-FU and mitomycin C. So we gave just one large bolus dose of radiation, because this was an acute study. And then we gave the chemotherapy agents twice over this 12-day period. So basically once a week they were administered. And then at 12 days, we harvested the bone marrow and looked at both red blood cells and white blood cells. And what you can see is that with the radiation and chemotherapy, we see a significant reduction in red blood cell count. And this is below the normal range for a Black 6 mouse, and was statistically significantly lower as compared to our control animals. And treatment with the BMX compound was able to bring those levels back up into the normal range, although this was still lower statistically than the control. And white blood cell counts were also significantly lower in our PBS rad and chemo group, again below the normal range for what we observe in a Black 6 mouse. And treatment with the BMX drug was able to bring these back up into the normal range, and also were indistinguishable from the control animals. So there is some evidence that the treatment with the BMX compound can prevent some of the chemoradiation toxicities associated with the blood cells as well. So we then want to know what's going on in the cancer cells. So we treated some colorectal cancer cells, and we performed a clonogenic survival assay on these cells. And we used 5-FU and radiation to kind of mimic the rectal cancer scenario. And when we included BMX into this mix, you can see that we're not protecting these tumor cells from surviving the chemo and radiation therapy. In fact, we seem to be further sensitizing these tumor cells to the rad chemo treatment. And then when we look at what we're trying to mimic for anal cancer, we're using 5-FU mitomycin C radiation, and then we throw BMX in. You can appreciate again that we are seeing another further reduction in tumor survivability in the presence of BMX and these chemotherapy agents. So we don't believe that we are protecting the tumor cells from death when we combine the BMX compound with the standard of care. We also looked at this in vivo. We used 2 different colorectal cancer cell lines, HT29s or HT6116 cells, and we gave radiation. This case, we gave radiation at 2 grays, 5 days in a row. So it's a short period of time. And we treated with the BMX compound during a radiation and then a week after a radiation. And you can see that with BMX, there really was no change in the tumor growth. So we were not protecting the tumor cells when we treated with radiation alone. And then to mimic what goes on with rectal cancer, we gave radiation and followed up with 5-FU. And this was a weekly dose of 5-FU. And we also treated BMX during a radiation and then a week after a radiation as well. In this case, we gave radiation at 5 grays, 5 days in a row, so a little bit higher dose of radiation. And you can appreciate here with BMX, we actually see a significant reduction in the tumor size all the way through our experiment. And we, again, are not protecting these tumors from the chemo radiation combination, which is exciting and something that we need to demonstrate, before we could actually put this into patients. So this was all the data that we collected to actually begin trials in both anal and rectal cancer patients. And Dr. Chelan is going to show us the results from this in the next upcoming talk. But before I leave, I'd like to acknowledge the people that did this work that I showed you. For my lab, Dr. Annie Kosmachok was the person that spearheaded this and did a lot of the in vitro work. And Dr. Peter Chatterjee, who was an instructor in my laboratory, did a lot of the in vivo work that I showed you. I would also like to, of course, acknowledge the collaborators, Dr. Chelan and Dr. Sikong Lee, for their help with radiation of our animals. And then I also like to acknowledge Amy Filler-Katz for her help in the clinical trial. And also I'd like to acknowledge some of the collaborators that we have at Biomimetics that's supplying the drug for us, Dr. James Crapo and Sarah Penchoff. I'd like to acknowledge our funding and thank you for listening, and we're happy to take questions afterwards. So thanks.
Thank you, Dr. Deegan, for